So I have the great honor and distinction of debating a very good friend in Stephen Coombe. And I've taken the high road, Steve. So at some point, if you have anything you want to say in a derogatory way, I'll just leave that to you. Singapore is not known for the derogatory statement, so we'll see how clean this is. What works here, and these are all my conflicts. So trials to date, all SFA trials with little exception enroll to the P2 segment. There's very little data when it comes to the popliteal segment. There are no large-scale trials in P3 or below. Most of them are registry. Comparative trials are non-existent. But the popliteal remains a challenging area for endovascular therapy. It becomes critical to understand that this area is a bypass target. Complications, like the tibials, are not well tolerated. If you really screw things up there, you can screw up a lot for a patient who is, PK was just describing, first do no harm for a claudicant. And then leaving nothing behind in this location, in my opinion, is really the best initial and probably recurrent strategies when it comes to therapy for this location. What about some of the data? Well, for the IN.PACT SFA and IN.PACT, but more importantly, global studies, they had popliteal involvement not described as P2 or P3, but just popliteal involvement. Now remember, your popliteal really starts at the adductor. But in the IN.PACT global of almost 1/3 of the cases, in the IN.PACT device, the pivotal trial was only 6 or 7%. So you can see there's a huge variation in where we infer the data where none exists. And so at least from the global standpoint, it looks reasonably good. In the complex lesion, which is the only one where you probably will glean at least some group that had popliteal involvement, the popliteal involvement on a 28-centimeter lesion metric, again, core lab adjudicated, had an 89% primary patency in this global cohort. That's remarkably consistent with what the pivotal showed. And again, IN.PACT is a non-endoprosthetic. What about the long lesions from Lutonix? So long lesions up to about 22 centimeters, plus or minus a smattering of around 8 centimeters, with about 8 out of 10 being CTOs. The long lesions, by definition, have to involve some form of the popliteal. And the freedom from clinically driven TLR, i.e., I feel better, doctor, after you fix my leg, is 88 to around 80% over 2 years. And that's a fairly consistent number, but also a fairly good number. One trial that I helped lead that I really want to focus on because it's one of the few trials that actually shows data specific to the popliteal. And if you look in the claudicant group, this is reference 1 to 3, the target was the popliteal in about 15% of the patients. In the CLI group, part of a multi-level disease standpoint was about 17%, and overall about 16%. But I really want to draw your attention. This is core lab adjudicated 2.4 PSVR specific to the popliteal with a directional atherectomy and just POBA, not a DCB metric. 77% primary patency on a 6-centimeter metric on the claudicant group. But look at this, 68% on a 5.4-centimeter metric in the CLI group. This, again, is a remarkable set of numbers that are core lab adjudicated, both sonographic as well as angiographic. And these numbers are actually quite good for a directional atherectomy. Liberty looked at orbital atherectomy. We chatted about that in the last talk, but their target was popliteal in a fair amount of their patient population in the claudicant group. Again, as we showed in the last talk, it was primarily an orbital atherectomy registry with PTA being their principal outcome. But in the claudicant group, again, they only report primary patency in the claudicant, not in the CLI group, was 83%. They do not break out, although many of the investigators are here. It would be interesting to find out if they broke out specifically the popliteal data set. That's the male. So the popliteal, in my opinion, remains a no-stent zone for a myriad of reasons. All trial designs, if you want to do evidence-based medicine, are really non-specific for the popliteal, with one very important exception. But the PTA and stenting may afford an optimal initial result. It looks pretty. But the issues of restenosis cannot be overstated, and it's really our Achilles heel when it comes to an endoprosthetic. DCB data appears compelling in this territory. Popliteal segments seem attractive for this technology. Atherectomy, in my opinion, is now demonstrated and proven beneficial in the entire popliteal segment and infrapopliteal segments. And popliteal should, I'll defer to my colleague, Dr. Coombe, remain a no-stent zone. Thank you for your attention.